how about if everybody just keeps it short? We've got two presentations, so I think that'll be okay. If everybody just kind of makes it a very brief introduction, and we can save the longer stories for another time. What does that sound like for a plan, Sarah?
Perfect. So I'll,
Oh, I
I'll
think
go.
poor Sarah's frozen.
Sarah
Alrighty.
looks frozen. So you know what I'm going to do is we're just going to start. Why don't we just do a quick round of introductions? Who are you? Where are you from? And something that you're thankful or grateful for. What about something like that? Just something quick. And so I'll start, and I'll just say my name's Kathleen Shador, and I'm the CEO of the Institute for Health System Transformation and Sustainability. I live, work, and play on the traditional and
Its other rising pans over lunch was perfect, and now it can get baked later on this evening, which will be great. And I'll pass it over to Trisha.
I'm Trisha Thorpe. I'm director for the Thompson-Nicola Regional District. I live on the Inner territory down near Lytton. I also sit on the board for SILGA. And today I'm grateful for my four
somebody.
Yeah, how about let's go to Tiffany?
Hi, everyone. I'm Tiffany Halisky. I'm with Philips. I am the strategic account executive for British Columbia, and I cover all modalities, including all of our diagnostic imaging portfolios, as well as our enterprise.
Partnership tables. And I'm joining today from the RCCBC office in Vancouver on the traditional unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples. And my gratitude is there seems to be a lot of food gratitude today, and I'm going to add on to that. Where today in the office, we all ordered in tacos. So it was Taco Tuesday here at the office. And yeah, it was nice getting to sit and have lunch with all my colleagues. And I'll pass to Ed.
Thanks, Shannon. My name's Ed. I'm the director of the Type 2 Diabetes Network under IHSTS, Kathy and I are colleagues. And I'm looking forward to presenting on the T2D Network today. I'm joining from the unceded territory, the Okanagan Silk peoples, and I'm most
privileged to be that. And then my wife has prepared some good. I just finished microwaving it and it tastes fantastic. Fried rice, my favorite. So very, very grateful for that activity. So maybe I'll pass it to my associate, Joanne.
Thank you, Kendall. My name is Joanne.
Give my car suspension a workout that I didn't know I needed.
Okay, perfect.
Which is nice. But yeah, glad to see everybody.
Great. We can hand it over to Anton, perhaps.
Good afternoon, everyone. I'm Anton Meyer. I'm a repurposed family physician that is blessed to spend my time and my life and my work on the traditional lands of the Silk people here in Vernon, where I live and work. Deeply grateful for grandchildren today. I have this blessing to be able to live a second life through the eyes of those much smaller than I, and I can walk with them. And last night, our two grandchildren, 7 and 10 in our home, the blessing to sit and answer innocent questions and depart some of the stories that we have in our lives. I am with RCC, the physician lead for the Personal Health Record Project, as well as the data informatics and artificial intelligence work for RCC. I'm also the co-chair of the Dean's Council on Rural for UBC, and I'm the vice chair of Health Quality BC, and that's what I do in my professional life. Great to see you. Kathleen, I came a little bit late, so I do not know who to pass over. You can help.
I think, is it Eimer?
That's Lisa. Lisa
Is that
Meir.
Lisa? Oh, okay. Lisa?
Hello, my name is Lisa Meir. I am with Pacific Blue Cross.
Oh, yeah.
And I am very grateful to be coming to you from the unceded traditional territory of the Coast Salish people, specifically the Musqueam, the Tsleil-Waututh, and Squamish nations. And I'm actually coming to you from work today, which is in Burnaby in the Coquitlam Nation. I think, just having the opportunity to be in BC and with a huge network of friends and family, I have a lot to be grateful for. And I actually want to, and it's a big gratitude, and it's all of my friends and family. I had the opportunity last night to have 2 of my daughter's friends over for dinner, and I got to spend a whole night with them just talking and telling stories. So I am so eternally grateful to my whole network. So thank you all.
Wonderful. And then Sarah, I don't know how your internet situation is, if you're able to introduce yourself.
I moved into my
I'm
sunny
not
space.
entire-
Can you hear me okay? Yeah. So
Yep,
maybe
we
I
can
can
hear you
get
fine, Sarah.
solar and Wi-Fi at the power of both. Who knows? So sorry, but I think the signal, I can always double onto my 2 bars of cell service here if the Wi-Fi goes down. Well, so thank you for putting up with me and my shoddy internet. I think Kathleen jinxed me. No, just kidding. So
I know, I'm sorry I asked.
it was working all up until then. So I'm Sarah. I'm the executive director of the BC Rural Center. I think I know all of you. This is my first chance meeting Tiffany face to face. We've been back and forth. We're so happy to have Phillips join us today and to learn a bit more about the link sectors and how they can fit in and through BC through health services and health systems. And I'm excited about today to learn more about IHSTS and the amazing work that Kendall and Joan are doing. And I'm probably frozen because it looks like maybe not. But yeah, I'll give it back to Kathleen to go, but I think we're going to start with Ed's presentation.
Perfect. Thank you. So 2 lines of context, and I'll turn it over to Ed. I'm the CEO of IHSTS. One of the initiatives that we lead, funded by the BC Ministry of Health, is a type 2 diabetes network. Sarah and I have had some conversations as co-chairs thinking about this link sector table is got such a group of dynamic individuals, and how can we bring things to you? How can we bring things to you? Sorry, my apologies for that. I can't do much about it. So I'm just going to turn it over to Ed, and I'm going to put my phone on mute till the noise stops in the background. Apologies for that. And Ed, I'm going to turn it to you, and you could start with your presentation on the Type 2 Diabetes Network.
Perfect. Thanks, Kathy. Give me a minute here to share because it's been some time since I've used Zoom. Let's see if this is going to work.
I think something to think about while we're doing these presentations is we're trying to find ways that we can begin working with rural partners. There's a lot of great information and presentations. And I think we could think about it from that lens, which is how can we use this in rural? What are the questions that we have from a rural perspective for both of our presenters today? So yeah, over to you.
Thanks, Kathy. Can you see that start screen okay? Yeah, perfect. So as I mentioned, I'm Ed Smith. I'm the director of the T2D Network run by the Institute for Health System Transformation and Sustainability, IHSTS. Just to set some context, IHSTS also oversees the BC Centre for Palliative Care as well. So there's those two core components to IHSTS's current mission. Setting the scene for type 2 diabetes, there's estimated to be 1.8 million people in BC living with diabetes or pre-diabetes. 11% of the population are living with diagnosed diabetes, an estimated 20% on top of that with pre-diabetes. And then we're expecting a 29% increase in diabetes over the next 10 years, which obviously is concerning given it's such a lifestyle-focused condition, and it's so challenging to treat because of that. The network exists primarily because there isn't a clear chronic disease mandate from government. So with no clear mandate, we created this type 2 diabetes network to support people living in BC with type 2 diabetes. There's three core components to the network. There's prevention, self-management, and remission. Prevention being focused on catching T2D early, like under a screening exercise. If someone's pre-diabetic, trying to find programs that work for them so that they don't develop a case of type 2 diabetes. Self-management is for those already living with the disease and all the different ways that that can be managed. And then remission is something that is an option for some. It's a tool amongst a range of tools that potentially could see your type 2 diabetes reversed, but there's lots of different versions of what that could look like. This map you're looking at here gives you an idea of some of the programs and some of the initiatives that we have across BC. We've got a lot of initiatives undertaken in the Lower Mainland, Surrey, White Rock, obviously the larger the population, where we have some of our programs like T2D screening. It's an easier market to access, essentially. But we're also trying to access rural locations more as well. Work like our Métis Federation support, HealthLink BC, having some of those components be available to more than people just in large urban settings is very important to us, and that's an area that we're expanding. The T2D network runs out of a website that's tailored for two different populations. So there's the patients and caregivers, which are typically people who are either living with type 2 diabetes or their family, friends who are looking for resources and education to be able to provide support for those people, or healthcare professionals themselves. So we work with a group called the BC Diabetes Collaborative, which is a group of nurse practitioners across all of the health authorities in BC who are trying to standardize the level of care for type 2 diabetes. And they're an example of the healthcare professionals we work with to try and create resources and content that's useful for their patients. And obviously it's different depending on the area. It's different if you live in Metro Vancouver versus Prince George, wherever that may be, the different programs that may be available to you. So working with healthcare professionals through a resource like the website lets us get that information out in a way that works for a large variety of people. This is an example of a project that we work on in the Surrey community, just outside of Vancouver. We engage a pharmacy group in Surrey to provide public screening opportunities. So this particular example you're looking at here is at a Gurdwara in the Surrey area, and it's tailored towards the South Asian population. And we work with a pharmacist to provide support and links to divisions of family practice, for example, so that if you've got a participant coming in and getting screened for T2D, they can then have a pathway to receive care. And that's always been traditionally a challenge in this space, in the NGO space, of trying to provide screening opportunities. What do you then do to provide care moving forward? And that's where we're trying to create those links. So we have a dietitian attend these screening events to provide on-site care. on-site guidance for recommended dietary guidelines, things like that. And then also a patient attachment specialist from the Division of Family Practice who can help a participant get attached to a family physician if they are not already. Some interesting numbers that come out of these screening programs. The average age is 64. That's to be expected given the locations that we've been screening at so far. The male-female split, 78% female. Again, this is something that we do see with voluntary healthcare events, things like that. It's usually predominantly female. It's something we're trying to change with upcoming events and access more men. 54% are attached to a family physician. That number sounds low, but in reality, a lot of the participants who are part of these screening events don't have access to a family physician because they're either not a permanent resident or they're family members of someone who is. So the true number of people who aren't attached to a family physician is a little bit higher than that, but it's clearly an unmet need. And then comorbidities are diseases like high blood pressure, other chronic diseases, as well as T2D in some cases. And then that last one on the right, 16% of participants are tested with a random blood glucose over 9. And what that means is in this context, over 9 is the threshold for type 2 diabetes. Again, it's a little bit more complex than that because it depends if you've eaten recently and some other factors around your care specifically. But around 16% is what we're seeing with the number of participants with type 2 diabetes. And this is 200 or 300 participants per session. And we put them on roughly every couple of months in different locations. Another project we engage in, I really like this project because it says exactly what the T2D network should be doing. I'll just highlight, don't bother reading this slide. This is a poster that we put up to describe this project, but it's a combination of the CMHA Bounce Back Mental Health Program and the Small Steps for Big Changes Diabetes Prevention Program. So for people who have both a mental health struggle and pre-diabetes, this creates one program for those individuals to go through. So you can go through either Small Steps or the Bounce Back program first, and then it immediately feeds into the next program. And it just increases the quality of long-term outcomes for a lot of these participants. It's traditionally been difficult for people who are suffering from both of these conditions to set goals and maintain positive lifestyle changes after each individual program, but by combining the programs, you can create better long-term outcomes. And IHSTS and the T2D network facilitated this through grant funding for both of those programs to be combined. And some very positive outcomes coming out of that. And I really like this example because it shows what's capable in the NGO space in BC. You know, you can look at these standalone organizations, these standalone programs, and help combine them to create something that's got even more value to people living in BC with these conditions. And then my last example here, we work with the BC Métis Federation to understand the needs of their community members. So it's a bit of a blind spot right now in terms of what specific communities need from a type 2 diabetes perspective, or even a chronic disease perspective for that matter. So we work with the BC Métis Federation to survey their population to better understand what their needs are, whether it's access to medications, whether it's access to programs, screening, whatever this might be. What are the challenges in these particular communities, and how could we as a T2D network help fill those gaps or help connect them with the service providers who fill those gaps? So we're in the middle of that project at the moment. As we move forward, there's some primary areas of growth that we'd like to see over the next year or two for the T2D network. Rural healthcare provider and community support, that's a big one. It's clearly, it's challenging enough for a lot of people to access these resources in urban settings. So it's clearly a need in rural for services like screening, more education, awareness about T2D and the lifestyle changes that are associated with it. So that's a big area of growth we'd like to get into. Public screening, as we talked about, we're expanding into the White Rock and South Surrey area through grant funding through the Peace Arch Hospital Foundation to facilitate public screening there. online resource awareness. We've got a partnership. Well, I don't want to call it a partnership. We've got an application in with Google Advertising that supports NGOs to provide advertising for health awareness content, which we work with to boost the amount of exposure our website gets and the amount of awareness that we can raise relating to T2D. Standardizing T2D care province-wide, that's the BCDC group I mentioned, the group of nurse educators who are trying to standardize the level of care and access to resources across all the different health authorities. And then lastly, non-government partnerships, which is relatively new for us, but we realize that there's only so much capacity in the established healthcare system. So how much kind of extra value can we provide by partnering with unconventional organizations to provide better outcomes for people living in BC with these conditions? This is a bit of an interesting diagram. T2D is obviously a big problem, but we don't want to pretend it's the only problem. And to recognize that, we've drafted this model of what a community network could be that focuses on chronic disease. So taking all the learnings that we've had from the T2D network, what would a model look like that you could apply to other chronic diseases to create capacity where there historically hasn't been any? And these are some of the components of that model. So things like tailoring options to the cultural needs of the population. I mean, we do that in the South Surrey projects relating to screening. We're talking about working with the BC Métis Federation and tailoring the content and the needs to that population. It's the same for any community. They're going to have a specific need, and tailoring it is important in some fashion. And then just to pick another one, research to practice. That Small Steps for Big Changes diabetes prevention program is or has its origins in research, and trying to help them bridge the research to practice gap by working with someone like Bounce Back is something we kind of focus on and could see being applicable to other chronic diseases. So this is the T2D Network newsletter. That's the link if you're interested in learning a little bit more. Also my contact information on the left. And then Sarah and Kathy, I'm not sure if we've got time, but in case there's any questions or comments about the T2D Network, I've got some other questions for this group about if you've noticed any health challenges in your communities that would be relevant to discuss with a forum like us at the T2D Network. And then also we're interested in exploring options to provide education opportunities in a rural setting or in communities that are tailored for that community, and wondering if any of your communities are interested in participating. So I'll open up the floor to questions and comments. I think you're on mute, Kathy.
For that, barking dogs. I just wanted to check in with Sarah. Sarah, I think we're okay for time. If we want to give 10 minutes for questions here and then over to Kendall, and making sure we give Kendall the full amount of time, and then 10 minutes of questions. And then if there's extra time at the end, we can kind of have a random mix of questions. Does that feel okay for you?
Yeah, I love it. Let's go.
Yeah,
for sure. Thank you, Ed. Excellent presentation.
Thank you.
Yeah, I think that was really, really, so thinking about that from a perspective and your community, how can this work link to your community? How can the Type 2 Diabetes Network be of use or value to you as you're working to try to support your communities? And I'm wondering if anybody has any thoughts or questions.
I should mention I'm certainly open to receiving emails from anyone if something occurs to you at a later date.
I'm hearing some quietness. I'm just, hang on, I've got a few people here. Lisa, do you have a question?
Yes, thank you very much for your presentation, and would love it if maybe we could get a copy of the presentation afterwards. We at Pacific Blue Cross, we cover about 1.8 million people, obviously some in the urban center, many in remote and rural communities. We have a ton of information about education and awareness on our website. We promote a lot of different things. So would love to get you in touch with our vice president of pharmacy, and she's actually a certified diabetes educator herself. You probably know her well, and see what she could do to get your material out, at least onto our web.
That's fantastic to hear, Lisa, and it's also very prescient because it's an R DOSAR, is that correct?
Yes, you got it.
Yes.
Yeah.
So we've worked with her a little bit to try and create a T2D resource for Pacific Blue Cross membership to learn a little bit more about the disease and some of the mitigating options. We're currently talking to her, but it's obviously the more people at Pacific Blue Cross who are aware of what we're doing, the better. So certainly, thank you so much for the contact.
Okay, thank you.
And then Terry, I think you're next.
Yeah, great. Thank you for the presentation. My question is kind of related to a problem that well, I'd say almost all of the members of the North Central Local Government Association face, which is just access to healthcare in general. Many of our members, particularly rural members, may not even have a doctor. So these types of networks are even more important in the absence of those types of regular points of contact. That seems to be like the primary focus of kind of local government right now, is really making sure that there's equitable access to care. And so I could see this being a mechanism that would be highly relevant to many of our members. And so again, I'd just like to invite you, if there's a chance, we could perhaps share some of the information on the network to our members through our newsletter or through our annual conference, or if there's a chance for you to come in and or some to talk to the board, those types of things, to share the information, to get awareness out that these types of programs are out there and exist. One of the focus areas we're working on right now is around mental health and addiction as well. And so again, there's a mental health component to this work as well. And so I could see overlaps there. Yeah, really exciting stuff, and happy to learn more as we go through the chat.
Yeah, certainly. I can provide some of that content after the meeting. It reminds me of the it reminds me of the Small Steps program again, that they have a virtual version of their program that they're trying to get more awareness in rural communities, because typically it's run through YMCAs in urban areas. But they're trying to create a virtual version specifically for rural communities that's at the moment based out of Prince George. But yeah, there's so many of these programs, they're so valuable, but getting the awareness out there is a challenge.
Great. Thank you. And then I'm going to see if Kendall has a question. I'm just going to flag for time here. We've got a few other questions lining up. We're going to go in order. And then I think around the 2:40 mark, I'm going to kind of stop. And then we're going to turn it over to Kendall to do his presentation. I don't want to take too much of Kendall's time. And then we can go back and revisit outstanding questions at the end.
Thanks,
Kendall, do you have a question?
Yes, thanks, Kathy. Again, so nice to see you again. And I know we met when you first stepped in the IHSTS role. Ed, great presentation. My question, I love the way that you start to not just look at silos of diabetes, but start to go to mental health and also palliative care, etc. Do you find in the areas of, I'm sure there's, but the areas of prevention, self-management, and wellness, that are there things across the programs that would be worthwhile for us to pursue together?
Yeah.
So, welcome your thoughts, and whether there's something that there's opportunity for synergy with you.
Certainly. I'll contact you afterwards. I mean, the prevention one has historically been a challenge because it's such a capacity limited system. So connecting all three definitely in one kind of holistic path for people to follow through would be very ideal. So yeah, let's connect on that.
Yeah. I think maybe I can just add one last comment on that as well, Kendall, is, I think when we start looking at things like the chronic, expanded chronic disease models, and we acknowledge that the lifestyle interventions are appropriate and applicable to a range of chronic conditions. So, that was where Ed's, slipped a couple of slides in. When we started thinking, we're working on creating a mechanism to support type 2 diabetes, but we also know that a lot of the interventions and activities can be applicable to other things. So it's almost that there's a core set of fundamental activities, and then there's a few disease-specific things that we need to think about. So I think it would be a brilliant conversation to start to have more conversation about how do we engage in that chronic disease management space, knowing that it's not just single intervention for single diseases. Yeah, great. Anton, you've got a question?
Thank you for a great presentation. So I'm curious to understand a bit more from your side. Do you struggle to get engagement at community level? And as you contemplate perhaps a response to that, my learning between 2000 and 2018, spending more nights per year on a bed on reserve than I spent in my own bed, I began to discover that obviously we know when you see one rural community, you've seen one rural community, and each community has their own way that they have a culture and how they do things. So what we did through a program that I did in Manitoba and Ontario, we connected with the grocery stores. And we made sure that we try to impact there. I'm wondering if you have that as part of your aim to do so. You mentioned that you already have connected with the divisions of family practice in the Fraser Valley area. I would strongly encourage you, wherever you seek engagement at community level, to work through the divisions of family practice. I think that's just a strong intent. And then within Northern Health, you know that they have a lot of Northern Health owned and operated clinics at community level. And so that would also be a place that you can really have an impact through a program. And I'm sure you've raised awareness to that. But again, that question, do you get responsiveness from a community, from a division of family practice? Is there awareness around what you do? And is there something that we could help with that collectively from RCC side, perhaps?
Yeah. The short answer is yes, we do see good engagement from community service providers. When we have something quite specific, we're going to them with. So that's the caveat. If we go into a conversation saying, this is what we think we can provide for your community, this is what it could look like, these are the benefits, we get quite strong engagement. When the conversation is more abstract and we're less aware of what their community's needs are, it becomes more difficult to engage. And I think that's just a capacity limitation problem. They've only got so much time to spend with you, explaining what the challenges are of your community. So that's where some of this screening work comes in. Is it's a very basic, kind of easy to understand idea for a service or a capability we can add to a community. And just to piggyback off of the grocery store comment, some of the pharmacists do work with volunteers that provide grocery store tours for people to become more aware of what a diabetes healthy diet would look like. And that's part of this kind of package of multidisciplinary people who are involved in those screening clinics. So the short answer is yes, but it comes with caveats of making sure it's a very specific ask when we go to healthcare service providers. As for community organizations, we always see that there's huge demand for these types of resources and content. If it's an NGO or a charity or a community organization that is not kind of part of the formal healthcare system, they're always very eager to engage. But again, funding can be a challenge with working purely with those. So it's usually a combination. But we do find good engagement in general. Haven't explored the rural side that much with some of the specific clinics in rural communities. So I could imagine that you could be very helpful there in making those connections.
Good.
Thank you.
Okay, and I'm looking at the time, and I want to make sure that Kendall has appropriate time for his. Trisha and Carrera, are you okay if we, so Ed can take a look at the question in the chat, Trisha, and then after Kendall's presentation, there'll be a bit more time for questions that he could go back and answer that, or Ed, you can answer and respond written in the chat, and then Carrera, we can get to your question later after Kendall's. Is that okay? Yes.
Thanks,
okay.
Kathy.
Perfect. I'm going to turn that over to Kendall then. I'm welcoming Dr. Kendall Ho. And we've had him present in other times. And I think most people know him or know of him and of the brilliant work that he's been doing in the world of artificial intelligence and virtual care. So Kendall, I'll just turn it over to you.
Thank you, Kathy, for what a kind introduction. And Sarah, thank you so much also for both of you to make this time available. And I really want to thank the committee members for allowing us, my team, to be able to participate in this meeting. We plan to speak no more than 5 to 7 minutes and really want to use all the time to talk with you and seek your thoughts. And what we're very interested in is this question. How can AI help community members in seeking health and wellness? And the question we'd like to bring to you today is, how can we work with you to ensure that the rural, remote, indigenous voices are heard? And how can we make sure that our rural, remote, indigenous community members can participate in some co-design of this together? As we discussed, I'm a professor at UBC Faculty of Medicine, and my unit is called Digital Emergency Medicine Unit, and we're very interested in understanding how technologies, AI, and data can support the safe and high-quality transition of patients between hospital and home. Emergency always sit in that space when patients, beyond their prevention, beyond self-care, they feel that they need help and they need help urgently. Emergency certainly wants to be there and support our patients. And when we send the patients home, we need to make sure that they feel safe, they feel that they're good, well supported. And so how can we look at data technology, not as the star, but as an enabler to make sure that that path is smooth for the patients. And that's why in this case, that at UBC, there is a grants, a UBC Research Excellence Cluster grants, and we're able to obtain one from UBC so that we can explore the area of use of AI in health. The name of our center is called AI and Technology Enhanced Care Collaboration Center, and AiTECCC. I wonder if Joanne, could you maybe help start to share the slides, perhaps? Maybe I can do. Oh, there you go. Thank you. And so we will, in a few moments, hopefully, we'll see the slide very soon. I'll keep talking for now. The idea of how, thank you. We're starting to see the slides. If you can put in the presentation mode, that would be amazing. And so what this cluster, it was established in April of this year. And the idea is that how do we create a network for dialogues together to support the advancement of use of AI in health? AI is going so fast. Short 3 years ago, that was just entering into the scene. And now using AI for physicians and nursing offices or emergency department to record history is already considered, routine practice. Many people are now using ChatGPT, generative AI, to seek help and support. And in fact, Ed, that was one of the reasons why I asked that question in the area of prevention, in the area of self-management, in the area of convalescence, and also Kathy, in the area of chronic disease management. A lot of people are turning to that. The question is, how do we make sure that as AI advances really rapidly, that we can work together so that we can ensure that AI is designed well, so that it can use the data well, and so that it can support the health system well. And I'm very fortunate I got to meet Tiffany. In fact, last fall period, I think it's fall, that we had some lunch talking about how can we also, with the private sector, really advancing AI rapidly and uptake of AI, that the patients' voices, community voices are also heard and move that forward. And then, of course, for the government, the challenge is if they were to set up good policies to advance AI, that is not only that the policy need to be set up well, but also how do we bring the voices to the table? How do we as health professionals, health organizations bring the right information so that the AI is not using partial information to lead to biases? So these are things that we absolutely need a community together to discuss. And in the rural remote, it's a very important area, as Terry, you mentioned about the fact that access to health services is a challenge. And so how can we use AI not as the major way to go, but as a way to support patients so that we can increase the ability to deliver services? And how do we make sure that AI is used in a culturally safe, ethical, and evidence-informed AI? Those are all the areas that we're very interested in identifying a social network, a network of folks that we can bring together so that we have that dialogue. Maybe I'll pass it over to Joanne so that we can give you a little bit more details, and I'll come back at the end, and then we'll have a bit of a dialogue together. Joanne, let me pass it over to you.
Thanks, Kendall. So just to continue on what Kendall has been saying is that a group of 20-something members and partners with interest in AI and healthcare and advancing equity within AI came together for this initiative, and the objectives for AiTECCC is at the foundational objective is to engage with community. The idea is to understand have that meaningful discussion and reciprocal community involvement in terms of digital health and AI. How do we make sure that we are moving to the other objective? How do we inform policy and health policy with the community engagement and making sure that it is implemented through evidence and human-centered approach and and move towards a system level change. So not only this, but hoping with the community engagement is that we support the advance the learning health system in terms of learning and compassion-driven care. So we want to inform decision-making through the policy, and we also want to make sure that we are advancing the other interprofessional and advancing learning through that engagement. But also another objective is that we're looking at is how to bring into that health private sector to listen into all this conversation and make sure that they are listening to the community and based on the community need. I think Anton mentioned that each community is unique. So what are the commonalities between the communities? What are the interests within the community to learn about AI and how they are engaging with AI? We want the private sector to be able to listen to the community and scale innovation based on community needs. So AiTECCC has been gaining momentum since it has started since April, and as I mentioned, we started out with 23 members within the founding members, including RCCBC, FNHA, and other educators such as an advisor and Indigenous advisors. We are supported with an Indigenous advisory committee that is led by also FNHA, UBC Digital Emergency Medicine, the unit, as well as UBC Indigenous Advisor and other elders, Indigenous elders from different PHSA and others. So how do we make meaningful engagement with the community through this, their support as well? So we are looking at, for the first year for AiTECCC, we're looking at the community engagement and listening. We want to listen to communities who are experiencing equity areas and who are facing systemic barriers, including the rural, remote, and Indigenous communities. But also we want to listen to multicultural communities. So we're having engagement with the South Asian and the Chinese community, as well as community members from experiencing medical needs, such as a spinal cord injury members. We want to also engage with youth and get their perspective in terms of AI and how they are using AI and how this is affecting also their mental health. So this is something that we want to listen to and taking all this engagement and learning and supporting in understanding the lived experience, but also identifying some of the benefits and concerns that they have and the risks that they're experiencing with AI, but also assess also the expectation of AI in healthcare and surfacing some aspiration and needs in terms of the use of AI within their community, either it's rural, remote, or Indigenous community, or happening in the urban sector as well, and inform responsible AI use design and inform policy. So I'm going to pass it on back to Kendall on this one. And so the aim is to bring all this engagement into a forum, and I'll pass it on to Kendall for this one.
Great, thanks. So folks, we really want to spend this first year doing a lot of active listening. Doesn't mean after this year we won't listen, but we certainly want to start the foundation with listening. We all know that if you have an imperfect data system, then it may bring an answer that would serve those who are in the majority, but those that are underserved would not have that representation. And so at this point, if you think about all the generative AI and searching out for knowledge, and also for those that are used in health system, our health system inherently has a certain challenge in the sense that there's served a lot of population, but there are many underserved population. And so we absolutely want to go and listen to what are some of the challenges. For example, the rural remote, and that's why this table is so important. And Sarah, again, thank you so much for our dialogue together so that I can come here for this dialogue with you. So we're reaching out for this table to say how we'd love to hear your thought and advice. How can we engage our rural remote communities well? You heard about our really learning a lot from the Indigenous Advisory Group. We're looking at some of the underserved groups. For example, spinal cord injury is one of those groups that we work with Rick Hansen Foundation and Spinal Cord Injury, BC, and also looking at the youth population. And so what we'd like to do is to do a lot of listening this right up till the forum, which is in mid-June. And we'd like to invite all of you, if you have time, to be able to participate in this forum mid-June. We haven't fixed the date, but looking around June 19th to 20th is likely the date at this particular time. So we can bring this together. And we have health policymaker of Ministry of Health interested in this, and 811 in terms of the urgent and emergency care. Let me disclose I'm medical director at 811, so in some ways very fortunate to have that, but also trying to understand things like hospital at home. How can we use these type of opportunities to support patients? And so the discussion I have also with Tiffany is we'd love to also invite the industry sector to join us to say, how can we work together so that we can truly advance AI to support patients' care? And so I think at this point, I'm just going to stop there. Not only are we going to focus on British Columbia, we do have national organizations that are interested, the middle column, but love to talk more. But today's focus really is to seek your thoughts and advice. If you feel that this is a useful opportunity, how can we work with you to engage our rural remote communities so that we can hear their voices, bring that representation, and bring that information forward? Thank you very much. Really appreciate that. Let me open this up for dialogue. So Kathleen, should I bring it back to you for moderating this, or
I can certainly moderate this. Just looking at the chat, and I'm going to do Terry first, and then we're going to go to Anton, who's got his hand raised. There's a comment from Terry in the chat about how AI can significantly improve rural access to care, but success depends on the trust and clinician oversight and the infrastructure. And I wonder if you have any thoughts or comments on his comment there, just to kind of open up that dialogue. How are we going to support clinicians and patient control, and how do we support that in a low bandwidth settings, and make sure that we're actually providing something that's effective and efficient for people who live in rural spaces.
Yeah, thanks, Terry. Appreciate that. Maybe I'll spend no more than half a minute to start. If you have any questions you follow, I'd love to go with you. Anton, absolutely want to come right back to you right after. Absolutely. I think there are several things about rural remote very important for me to understand. I don't grow up in rural remote, so I learned it from Anton, I learned it from Dr. John, I learned it from Ray Markham, RCCBC. And the challenges of digital divide, the infrastructure, the connectivity, the challenge of the healthcare system itself, that often the urban system tend to dominate the budgets, the funding, the services, and rural remote sometimes don't have access and equity of access to those. Trust is so important. And to be able to really understand that, I'm not suggesting AI will solve all that problem, but it's very important for us to understand that if AI is an important tool for rural remote, how can we make sure we design it well? How can we make sure that we can bring that to the BC policy table and say this is important? And how do we start building that trust and trustworthiness? And so this listening, active listening, becomes a very important first step. But of course, it's not just listening. It's about listening and then delivering. And so we're just starting this baby step forward. But Terry, all your comments are well taken, and completely agree with you. Terry, I don't know if that kind of answers your question or any additional follow-up you have. Great. Thanks, Terry.
And I'll just quickly jump in on that connectivity one to say that the Northern Development Trust, so the NDIT, they've been allocated, I think I could be wrong, but like $300 million, like a lot of money for connectivity in the North. And so they might be a good partner to talk to about, as well as I think it was Naomi's comment about connectivity in the North as well. It's the main challenge, and Starlink isn't a solution. So if AI is going to, if we're looking at equity, then we definitely need to look towards making sure that we bring the right partners to the table by those people working in that connectivity for those remote communities.
Great comment, Sarah. Thank you. Anton, I'm going to turn it over to you.
Kendall, it's always great to connect and in this space to see that academia is actively working along this. I'm curious to understand. I love the fact that you have a few times expressed, and Joanne as well, that you want to impact policy, and through your understanding, how can we connect with government and make sure that they understand this? Because in the current climate, with this administrative reform that we are doing, or that we are seeing, I'm curious to understand at your end how that impacts you. What I do see is while this administrative reform can make the system more efficient, without a deliberate rural and indigenous lens, which it does not have, it will not make the system more equitable. In this moment of historic change within BC health system, the choices we make now will determine whether rural and remote communities gain stability or whether they will fall further behind. So we know that there is this optimization, procurement, and IT focus within this transformation, but there is nothing around the rural digital health modernization, and we just heard about it now. So how can we connect to make sure that that piece is so important to take into consideration when we want to educate, or whether we want to learn how a community wishes to engage around AI and how that can help them or not? What are the restraints for them to do so? So at the tables where you sit, I would strongly suggest a consideration to create a rural and indigenous equity table, advisory table, where you have RCCBC, where you have First Nation Health Authority, First Nation Health Council, rural physician medical staff associations, UBC Rural and Remote Health, for example, the Dean's Advisory Council that addresses this thing from the upstream side, education and so forth, right? So all of those elements are extremely important, I believe, as you go forward to try to address this from an equity lens and understand that our current system is not geared to support rural. It has a centralization impact. And when you do that, you leave rural behind every single time. Literature has shown this all over and over and over again. And how this money constraint will penalize those that's already being penalized significantly. And so in your journey, I would strongly encourage that you consider that perhaps.
Excellent. Anton, always love your not only commentary, but the expertise and experience that you have, and also the challenges that we face. I also want to acknowledge at the same time first that Anton, I've learned not only the fact that you bring up the issues, you actually take action on it. And so I appreciate that, and I really love to get your thoughts on this. Here are my 3 thoughts on this. Number 1 is you're absolutely right. If we continue status quo and not make differences, chances are there is when there's finance, when there's challenges with policies, etc., they tend to go to the larger volume and say, I got to address this. And so rural remote often gets left behind. I also believe that I think if we can shine a light on this together, and again, it's not just one group. I think, as you pointed out, it's multiple groups working together to shine light on this. It's going to be very important to get started, and also through the learning health system. And I'm going to bring that from a concept into practice, is to say, if there are ways that we can demonstrate steps that in fact we're not slipping and sliding, we're not just maintaining status quo, but we can turn the corner, that start to build trust of the community, build trust of the health system, and also hoping that one day we will have this, financial recovery. Currently, it's unfortunately geopolitics lead to many of that challenges. But one day, as we recover and improve, that the opportunity will be there for us to go in there and say, hey, we got to move that forward now. And having communities working together is so important. We have Ray Markham, RCBC, John Plovich, Terry Aldred sitting at our steering committee at AiTECCC. Absolutely want to work together. Anton, I'd love to get involved as Dean's Counsel. I'd love to maybe offline have a dialogue with you. And again, with this table, to be able to work with all of you will be a huge pleasure to be able to bring out the rural issues, to make sure the rural issues we remain, there's a shining light on it, and make sure that on the AI front that we can make those baby steps forward.
Yeah, that's great, Kendall. Thank you. Thank you, Anton, for your insights. And then next up is Naomi. Naomi, what advice do you have for Kendall?
I was just going back to the remote community thing. I've been with the Chetwynd Chamber for 10 years, and I sit on numerous committees with BC Chamber and our executives. And Northeast BC has been fighting and putting policy towards provincial government for broadband and connectivity in the north. And we have another AGM coming up, and we're renewing the same policy. Connectivity is a huge barrier for many. I have many of my members who I myself don't have internet access at home or cell service. And that can create a big problem. The other part is back in, I think it was 2019, maybe just at the beginning of 2020, TELUS came through and did this massive announcement for this big internet upgrade for our community, which only went up again to our border. So we did this big thing, and I was told by TELUS when I brought it up, TELUS said that the earliest that they were looking at doing expansion to outside of our community, which is like, it's another 5-10 kilometers even, was 2027. And that was back in 2019. And we still have not seen any progress on that. I have cable that runs right by my door on the outside of town, and I can't access any of it, which is really frustrating. But it comes, like I said, it's a big issue. And the other one was coming up about the AI is we still have our clinic here does a little bit of AI for helping with note taking and stuff, but there's still, even just sitting there, still a lot of distrust about it, especially with our elders and our seniors who are like, nope. So, and we all know that's the way that the world is changing and technology is going. And when it comes to reaching out to these rural and northern communities and the people who live on the outskirts, I encourage it, definitely work with your chambers, because we have that access to the business community into our municipal governments to help get that information out there. So I'll throw it out there if anybody wants to come to Chetwynd and come and do a presentation and jump in on a luncheon somewhere with me. We do business luncheons every month. I can throw you on the list. We are more than happy to do that. Just get a hold of me.
Fantastic. Thank you, Naomi. So absolutely understand the connectivity challenge. I don't pretend I can solve that problem for you. But what I can do is to say there's huge importance in content of that connectivity and add to your voice to say this is important. Secondly, I think, absolutely use of AI. We were engaged with the multicultural population as part of our group with the Chinese and South Asians, and seniors are hesitant about AI, worry about, would it be a scam, and also not sure how to learn it, but they would like that someone support them in their learning, which is very different from youth. They learn by doing. They say, I'm going to go in there and play with it, etc. That's how I learn. So very, very different approach. And so again, we need to realize that. And so love to come in to join you, to hear your community, and also what are their aspirations of using AI, what are some of the challenges, and then hopefully with that understanding, we can then bring ways to address the AI side, and hopefully also become an ally to you to support the connectivity side.
Great. It certainly sounds like Kendall and Naomi are having lunch. So yes, very nice.
I love lunches, by the way.
Perfect. I'm going to turn it over to Ed with the next question for Kendall.
Yeah, thanks so much, Kendall. Kind of a question around the specific component of AI that you're looking to advance. And the reason I'm bringing this up is to echo Naomi's thought, which is we've had feedback from patient partners that has been relatively negative on AI in terms of working with it directly. But then you've got all the way, in first principles towards, AI-assisted charting for physicians, which, improves efficiency and all the rest of it, that doesn't affect the patient experience as directly. Is there an intent to see AI tools used as a frontline piece of communication with patients, or are there more kind of nuanced ways of using AI that can improve processes that you're also interested in?
Yeah, thanks, Ed. Important question. I think one is, like or not, AI is here now. AI is embedded into healthcare. AI is embedded in image-based healthcare. AI is embedded in genomics-based healthcare. It's there. So I think the general population may or may not be aware of it. Secondly, I think this effort is important to say in the clinical decision support AI, that's currently not quite mainstream. Emergency medicine, primary care are areas where this is not mainstream yet. To ask AI to say, I need to treat that. Now, when we look at generative AI as a health professional, I said, wow, these symptoms, what would you come with differential diagnosis? And I would be amused and say, oh, this is pretty good. 80% of the time, this is good. There are only about 20% inaccuracy. The challenge for the patient, though, is they can't tell which 20% is not accurate. And so I think this presents an opportunity. We can stop people from using AI, but what we can do is to help people to use AI appropriately. And also, how do we as health professionals learn to partner with our patients together to use AI safely? And that's why, again, active listening becomes so important. And I'm going to quote you one more statistics, and then I'll stop. For youth, they use it. In fact, many of them use it for mental health. In fact, for youth, 60 to 65% in literature now, and literature we know is behind, so it's that percentage is rising. 65% of youth regularly use generative AI to ask about health questions. 20% of them use it for mental health to the point of being a confidant. And that word is important. That means that they would use ChatGPT exclusively without asking anybody else. So how do we look at these areas? It's being used. How do we work with our community members to use it well? And how do we make sure that the data is well used for the health system and health professionals use it well, such as, for example, type 2 diabetes on prevention, on disease management, on chronic disease management, on recovery and convalescence and wellness. How can we best partner with them? I think we got to listen to our patients. I'm not saying you are saying I'm not, but I think this effort is to make sure that we do listen, and also in the different community members, how do we best serve them? Yeah. So Ed, again, love to dive deeper with you in this experience.
Yeah, very much so. Thank you, Kendall.
Great. Thank you for that great conversation. Tiffany, last question for Kendall belongs to you.
Sure, yeah. And less of a question, more of a comment. I think you, Dr. Ho and Joan, you both described it so well. I think there's this trust gap when it comes to AI. We had our Chief Innovation Officer, Dr. Shez Bartovi, come from Eindhoven to Vancouver to meet with some of our key customers. And this was really the topic of the conversation, was this trust gap. And it's interesting because what it stems from is a fear of having less face time with the physician, that AI is going to take over your care and you're not going to be talking to a physician anymore, which is absolutely not the case. Is there to supplement the physician's work and support the physician so that they can come to a more accurate diagnosis by, in my world, in Philips, it's removing blur and noise from an X-ray so you can get a clearer, more confident image, and you can see something that you might have missed with the naked eye. And so this technology is not here to replace patient care. It's here to supplement it and improve it. And I think that trust gap is slowly closing and we're getting there in time. And I think the work that you guys are doing with AiTECC is so important to helping with that. So I just want to say thank you to you guys for everything you're doing because it's such important work right now in this day and age.
Well, thank you very much, Tiffany. And again, I have gotten to learn about your work and also in Phillips and also it's influential work that having that type of a pursuit is so important to make sure that there's good use of AI and technology. I think building that trust and trustworthiness takes time. And again, if there is no dialogues, then people would just be divergent. They're just parallel universe at best, if not getting farther and farther away. The dialogue is what causes us to be able to say, well, are we going in the same direction? And there may be areas that we absolutely need to go in the same direction. There may be other areas that we can say, well, let's learn a little bit and just keep talking so we can continue to build strength. And so AiTECC really is meant to be a forum for that dialogue so that we as academics, as researchers can bring some of those evidence, bringing different community engagement so that we can come together. And so June 19th, 20th, again, we're going to bring all the groups together. We have dialogues together. And then for year two, we then take some actions and continue to do action learning. So that kind of learning health system piece. So again, thanks, Tiffany. I want to invite all of you for that June 19th and 20th. In the meantime, I'd love to hear from you, maybe the Northern Development Trust I heard, the Chatwin Chamber, and also Terry, the Local Government Association, IHSTS, and also Anton. Love to talk with you about Dean's table and love to maybe start taking action to say, I'd love to say in February or March, where can we go in rural remote with you so that we can start engaging and start listening so we can move this forward. So thank you very much for that. And with that, Kathleen, I'll pass it right back to you. Thank you so much.
Right. And thank you for the presentations. It's and the fabulous questions. What I'm thinking about are two presentations, both different, very different in nature, but the ask is the same. The ask is the same. We have a group of very engaged rural people, come from various pockets around the province with various ideas and perspectives and challenges. And both of our presenters are asking how we can engage rural, how we can include rural, how we can get rural voices into the work and at the tables. So with that frame, we've got 15 minutes left. I think there were a few other questions, or maybe there's more questions. I'm going to turn it back out to the group. What kind of questions do you have for Ed or Kendall to talk a little bit more about their work and how we can engage rural? And your voice is important here because this is why we're having the meeting. This is why we're bringing in the presenters. So wanting maybe to narrow the conversation just a little bit more and talk a little bit about direct engagement activities or I've seen the chat go by and I think we've been writing down various people and various connections. So that's great. And what else? So Tricia, I'm going to turn this to you and see what kind of questions and thoughts you have.
It was more comment. The Jim Pattison Center for Rural Learning Innovations, they call it JP Center. Have you engaged with them? Because they have a whole sort of mandate to deal with rural and remote health and technology and Indigenous and a whole bunch of other things that they might be worth connecting with and see what they can do and how you could maybe partner with them.
Yes, great. So a fabulous recommendation from the type 2 diabetes space. We have been connecting with Dee. I think that relationship is growing just as the center's getting its feet underneath them. Kendall, I don't know whether I'm sure certain you probably have connected with Dr. Dee Taylor.
Thanks, Ed. I see you put the...
Thanks. Yeah, we very fortunate. I had a pleasure working with Dee for several years now, and I think excellent center. Directly on this work on AiTECCC, we haven't yet, but excellent pointer. That'll be my next email to her for sure.
I'll just check in quickly with Tricia. I know that center, I think it's based in Kelowna, and it's a center for health systems learning and innovation. Is that is the center you're talking about, or is there another Jim Patterson?
Nope, that's the center I'm talking about, and they are dealing
Sounds good.
specifically with rural health. So
Yeah. Okay.
it seemed like a good fit.
Yeah.
Perfect. Thank you. And Carrera.
Yeah, no, I just wanted to add in there too. And I figured Kendall, you're probably pretty linked in with Dee. That center is linked in through RCC, and Dee actually is one of our co-scientific directors with the Rural Coordination Center. So pretty linked in with the RCC BC.
Good.
Excellent. Thank you. Nellie Oak, who is a researcher at RCC. Again, she sits on our steering committee on AiTECCC for sure. So love to connect with Dee for sure. And Carrera, thanks again for that suggestion.
Okay. Carrera, did you have another comment from previous? I know that you had your hand up, so I just wanted to check in with you on that.
Oh, what was it? Oh, just wanted to also link in some other work too around and just really appreciate the presentation, Ed. And I know both you and Kathy are involved in the shared care type 2 diabetes work that's kind of going on with RCC as well too, and just thought that might be also good to link into the space as well too, some work.
Great, thank you for that.
And I'll just jump in and just sort of quickly share what I was seeing in the chat about and what actually Terry brought up, as so did Naomi, is that when you're looking to engage rural, and that's what the BC Rural Center does, that's what NCGLA does, that we've got electoral area directors on the call, Chamber of Commerce, all from rural community, is you really do want to make sure that there's a trust and a relationship there, that you're not coming in just in that sense of like to suck out information, but to listen to them. And that's why going in through your local government, going in through your chamber, or finding those organizations, whether there's a community health services nonprofit that already exists, the hospice, finding those local organizations that are grassroots in the community, which are led by the rural community, and not just being seen as another urban person coming in to say, hey, I need information from you because it's going to look good in my grant application if I have some rural data. So that's what we're all here for. So be sure to reach out. And I know that Kendall and I work closely. I've had some great conversations with both Ed and Kathleen about how to engage rural and some key aspects. And I always like the Chamber of Commerce in rural communities is so key. You have to go there, and your local government, they're elected by the residents. The residents have chosen these people to lead their communities, and not all of them, maybe they didn't get 100% of the votes, but they did win. And so they're actually a great asset to have on your side, because they too know who the stakeholders are in your community. So always really encourage. And I just like the theme that came through today's call around the equitable access, whether it was to type 2 diabetes, internet, AI, and that's what we're all looking at across rural and remote and First Nations, is equitable access to healthcare, and whatever aspect of healthcare it is you need, and how we can work together. Collaboration makes things so much easier then. So I'm so glad to be on this call today with everyone.
That's great. Thank you for that reframe, Sarah. Such an important point. We all know about the history and how everything starts in urban, and then the wild assumptions of the past, where you can just take something, build it in urban, and then just make it smaller and put it over there. And we acknowledge the fact that we've not done that, right? So it's always great to have the reminder of the way we need to think and the way we need to be, right? Thank you for that. Now, I saw Terry had his hand up, and I don't think it's kind of disappeared. So I'm going to just, before I move to Naomi, I'm going to check in with Terry and make sure that either he changed his mind or I did miss something.
No, I dropped it down, but I'll raise my comment, which is, please reach out if there's anything we can do to be of assistance. We're happy to share the information, and you've got lots of groups around the table, and they have willing audiences that want to be engaged and are keen to share information. So please do feel free to reach out to all of us around the table. The other thing I was going to suggest is that it may be worth we have about 39 local governments, First Nations, and NGOs that have signed a mental health and addictions accord, and it might be worth even looking at doing some targeted presentations to subgroups like that, on specific topics, because as you mentioned, the use of ChatGTP as a mental health support tool is really increasing. Yet most of our members are starving to get access to counseling care, right? So there's a real opportunity there for perhaps earlier buy-in conceptually.
Very nice. Thank you,
Excellent.
Terry. And Naomi.
Yeah, I was just gonna say I had an interesting conversation yesterday with a local business owner here in town, and she is a young business owner. I've been wanting to try to get her to come join and be on my board. She and her husband are actually leaving Canada and moving to Texas. They here her husband has a job there, but they can actually get. She was telling me she's lived here her whole life, but she's quite young. She wanted to know, why is our health system like, why do we have Northern Health? Why, what happened before? Like how? So I explained to her, because like when they changed it from the boards and they went to regional, yada yada yada.
Yeah.
And she actually told me a couple little horror stories about healthcare in a small town, because she has a child with special needs and that she doesn't have the access to the care that they need. And her husband is originally from the States, so they're actually leaving our community to go be down there. Just to be close to healthcare, which is like devastating, because you don't want. Well, I mean, I've heard of people not moving here because we have lack of healthcare and diversions and issues and no doctors and nurses and stuff. And then here we have a young woman who was born and raised here, loves her community, but feels like she can't stay because she doesn't have the healthcare supports and resources that she needs. So it was just. So I kind of had to give her a bit of a history on how everything all worked and what happened in the past, and it was. But it was still. It was kind of. It hurts a little bit to hear when you have these young families who are moving away. So hopefully stuff like this can help get some information out there and move forward and make a positive change.
Thank you for that. Thank you for that, Naomi. That's really, it's unfortunate, most certainly. And we all know we have a work to do. And as I think our collective impact is so important, and how we can work together. This is just one more example of where we need to spend some time. So thank you. And Lisa.
And I think my comments are sort of layered on what I'm hearing everybody say, and I look at the impact of this group and the depth of the relationships that we all have, or the influences that we have. And I think if we can use this group more to, as I said, education and awareness is, frankly, really lacking even in healthcare. Is when you have a need, that's when you have the access, regardless of whether you're in urban or rural, and it's sometimes very difficult getting that access, right? But I'm frankly really I've been really surprised as we have been rolling out information, and we continually roll out various healthcare supports to all of the people we cover. So I think the more we can work together, and we are always interested in putting more and more supports on our website for patient education. And of course, if those supports are trusted material from trusted individuals, I think that helps with the trust factor as well. So again, I encourage everybody to use all of us in terms of, if we're getting a message out, use us, and to be able to share it and expand it. I just think we've got a great group for that. Thanks.
Fabulous. Thank you, Lisa. And Kendall, maybe the last word may go to you.
Oh, wow. Thank you. Lisa, really appreciate what you said. And Naomi, that story is heartbreaking. Maybe I'll give a short story and finish in about half a minute. I was in a conference, and I have a person who lived in not rural, but in a suburban community, but has a child who went to ICU, and every time that person that child needs to go to emergency, she needed him to an urban area. And so they would call the ambulance, and the ambulance invariably would take it to the local hospital. Then they'll say, that's not right, and go to local hospital, end up transferring to urban. And so every time she called a health system, she has to be prepared to argue before making a dial. And the occasion where the paramedics understand right away and said, yeah, absolutely, and take her to the urban location, she'll feel really, of course, relieved. And so I had a chance to ask her, how do you look at the health system? And she was saying that, well, I have to count on luck so that I have a health professional help me. I think the issue is, I think it's great to have relationship. It's important for us to build it. I really love this community. If one day we can eliminate luck for rural community members so that they can get the care that they need, I think that would be amazing. I'd love to be able to work with all of you to get there. I don't think we can get there tomorrow, but I think if all of us work together, we can move closer to it. Eliminating luck would be very important.
So wonderful, and I think it applies to everyone and everything. It applies to our work. It applies to everybody's work as the leaders in our rural communities are trying to do the very best they can, and again, often with limited resources. So that may just be the tone and the theme of the day. I pulled out a couple of ideas that I've heard from the general dialogue. First of all, I'm grateful to be a part of this group, and I'm grateful to hear the passion and the emotion that people are bringing to this table. It's just always a highlight of my time when I look at my meetings and go, "Oh, I've got that one today." It's always exciting and it's always interesting to be a part of this. What I hear are things like, "Let's work together." And let's work together and share insights. And when we come asking for ideas and perspectives, the honesty and the genuineness of the feedback is just so enlightening. And then we have an obligation on our side. We've come to you and we've asked for assistance. You've given us, 20 brilliant answers and responses. And then now we are going to take this away and figure out how to use all of your feedback in order to be able to really bring this to rural, embed the rural voice in the work that we're trying to do. And I appreciate all of the conversation and all the dialogue today. Sarah, before I close up, we've got a couple of minutes. I just want to check in with you, see, first of all, are you there because your internet's behaving? And do you have any last minute thoughts or comments?
Yeah, no, this is great. I love the link sectors calls. I love the vibe that we get going and just how the passion for rural, like the amount of times in a day when I'm in a meeting and I say I love what I do because I get to work in rural and work with rural people who we're not resilient because we have to or want to. It's just who we are. It's we want to make things happen. We want to remove luck, but we do what we do because we're here. And having everyone in this meeting today, all these change makers and all these people that want to make it better, it's so positive. And I love when we're no longer that urban rural divide is we're taking that away. We don't want it to be seen as us versus them. We want us to see as together. We're doing this together. And yes, rural context is important at policy making. It's critical for rural areas, but to be able to not think about it as us and them, but as us coming together and that rural urban divide being demolished so that we can see success across the whole province. So yeah, thank you everyone. And I love co-chairing these meetings with Kathleen because when my internet goes down, she rolls. She just rocks it. So it's perfect. Thank you, Kathleen.
Together we can figure it out.
Yeah.
That's awesome. All right. Thank you, everybody. Have a wonderful day. And we really look forward to speaking to you again soon.
Thank you very much.
Thank you.